Hello everyone, welcome to this online course on ophthalmology from Joint Santo International Eye Center, the JSIEC. I am Dr. Huang from the Department of Retinal and Vitreous Disease. Today we'll talk about anterior uveitis. I hope that through this section you may be familiar with the anatomy, pathology, clinical features, diagnosis, as well as the treatment of anterior uveitis. Before class, I would like to share you a case that I experienced days ago. A young man came to our eye clinic for red eye photophobia and blurred vision in his left eye for 2 days. Slit lamp examination showed precipitates in the endothelial side of the cornea and floating object in the anterior chamber. What has happened to his eye and how to manage it? I hope that after this course, you can perfectly answer all these questions. Now let's begin our class. The uvea is the vascular layer of the eye and comprises the iris, ciliary body, and the choroid. Anterior uveitis may be subdivided into iritis, in which the inflammation primarily involves the iris, and iridocyclitis, where both the iris and the pars plicata of the ciliary body are affected. Anterior uveitis is the most common, followed by posterior, intermediate, and panuveitis. Acute uveitis is characterized by a sudden onset and limited duration. Chronic uveitis describes persistent inflammation with prompt relapse after discontinuation of therapy. Today we will mainly focus on acute anterior uveitis. The etiology of anterior uveitis remains unclear. The autoimmunity is involved, since the uveal tissue contains abundant vessels and antigen. Inflammation and antigen-antibody reaction are often active. In addition, prostaglandin production caused by injury plays a role in the pathogenesis of anterior uveitis. Infection can be another main cause, which the offending agent include bacteria, virus, fungus, and parasites. Lastly, we have molecular mimicry. Foreign antigens of microorganisms can initiate an immunologic response in the host. Sometimes these antigenic determinants are very similar to those of the host cells. The host cannot distinguish and will mount an immunologic response against his or her own cells, giving rise to autoimmune disorders. Anterior uveitis present typically with a sudden onset of unilateral pain, photophobia, and redness, which may be associated with lacrimation. On exam, we can see ciliary body injection with a violation hue. The meiosis due to sphincter spasm may predispose to the formation of posterior syncytiae. The carotid precipitates, called the KP, is a characteristic lesion which usually appears a few days after onset and are usually non-glomerulous. You may find either endothelial dusting by a myriad of cells, giving rise to a dirty appearance, or a large mother fat appearance, or sometimes opigmentic KP. Aqueous flare is always positive, which reflects the presence of protein due to a breakdown of the blood aqueous barrier. It is like in the dense forest, you can often see beams of sunlight through the branches and leaves. This is called the Tyndall effect. Flare may be graded using a flare meter or clinically by assessing the degree of interference in the iris using the same settings as for cells. Fibrous exudate is considered as intense aqueous flare. Cells in the anterior chamber indicate disease activity and their number reflects disease severity. Grading of cells is performed with a 2 mm long and 1 mm wide steep beam with maximal light intensity and magnification. Please remember that this must be performed before mydriasis because in normal eyes, cells and pigment clumps may develop after pupil dilation. Hypopyon is another feature of intense inflammation in which cells settle in the inferior part of the anterior chamber and form a fluid level. Posterior syncytiae may develop quickly and must be disrupted before they become permanent. Fundus examination in a patient with simple anterior uveitis is usually normal. However, it should be always performed to exclude a spillover anterior uveitis associated with a posterior focus, notably toxoplasmosis infection and acute retinal necrosis. The presence of anterior uveitis, particularly with discontinuation of therapy, will lead to various sequelae. Complicated cataract and secondary glaucoma requires surgical intervention, whereas an ocular atrophy could be difficult to save. So, a patient may come to you complaining of pain, redness, and visual loss, perhaps with a pertinent medical or family history. Ocular examination reveals ciliary congestion, choroidic precipitates, miosis, aqueous flares cells, then anterior uveitis can be strongly suspected. We should complete a systematic history, perform a thorough physical examination, and laboratory workup. The three treatments are mandatory for anterior uveitis are pupil dilation, anti-inflammatory agent, and antibiotics. Atropine is important since it can relieve spasticity of the iris and iridis sphincters, hence attenuating pain and inflammation. Let's summarize anterior uveitis often begins with an acute attack, photophobia, redness, and decreased vision. It presents with ciliary injection, choroidic precipitates, miosis, aqueous flare cells, and subsequent posterior syncytiae. Prompt clinical diagnosis and management are very important. On treatment, atropine combined with steroids and NSAIDs can be effective. In addition, since uveitis may be a symptom of systematic disease, further evaluation is needed for a definitive diagnosis. Here are the references. Thank you very much for joining us.